moving on now to we're crossing back to the USA. Next presenter is Dr. Matthew Sherman. Dr. Sherman is a physician researcher at the National Institute of Arthritis and Musculoskeletal Skin Disease, otherwise known as NIAMS, part of the NIH. He's a fellow in the clinical fellowship program at NIAMS, specializing in muscle disease. He received his MD from University of Pennsylvania, completed his residency in internal medicine at University of California, San Francisco, fellowship in clinical neurology at University of California, Los Angeles. His research interests include neuromuscular diseases, including muscular dystrophy and peripheral neuropathy, muscle biology, physiology, clinical trials, and translational research in muscle disease. And Matt's going to talk to us today about myositis and associated autoantibodies in JM. Over to you, please, Matthew.
Great, thank you much. So I'm delighted to be here. Really appreciate the opportunity to present and for CureJM for putting this all together. So I'm going to talk today about myositis-associated autoantibodies in juvenile myositis. And this work was done in large part while I was a fellow at NIAMS, now at NIAD, another institute at the NIH. No disclosures. Myositis autoantibodies were first recognized back in the 70s, and since then, a whole slew has been discovered. It seems like every year we get more and more. 2014, anticortactin, FHL1 the year after, and then in the 2020s, a whole host of other myositis autoantibodies have been recognized. And so in what's now probably an outdated figure from 2018, at least then, most patients in both juvenile onset and adult onset myositis had at least some autoantibody. And then about 30% of juvenile patients did not have a known antibody. This number is probably smaller at this point with better detection and a wider array of autoantibodies that we now know about. There's two key types of myositis autoantibodies. One, myositis-specific autoantibodies, or MSAs. These are, as the name says, specific to myositis, so we don't see them in other autoimmune diseases. They're mutually exclusive, so we would not expect to see two of these types of autoantibodies positive in the same patient. And they're associated with clinical phenotypes. So a good example would be anti-TIF1, which is associated with photosensitive cutaneous involvement, lipodystrophy. And then MDA5, which is associated with a syndrome often including alopecia, arthritis, ulcerative skin disease, and most notably interstitial lung disease. So in contrast to MSAs, MAAs, or myositis-associated autoantibodies, are present in other autoimmune diseases. It could be things like lupus or Sjogren's, and they often co-occur with other myositis antibodies, either other MAAs or MSAs. Whereas MSAs are associated with the whole clinical phenotype, MAAs, not to this point, seems to be the case. They may be associated with a particular disease manifestation. I think at this point, the classic would be interstitial lung disease with row 52, or increased treatment burden. And some of them are still not very well characterized. Myositis antibodies also more or less segregate into clinical subgroups. You have immune-mediated necrotizing myopathies with HMGCR and SRP. We have dermatomyositis with a whole host of MSAs, and then the antisynthetase syndrome with multiple autoantibodies all leading to the same constellation of features. And then we have a number of MAAs in this overlap category, which can present either as dermatomyositis, polymyositis, a combination of features. And just a few notes, because this is not strictly a JD or juvenile myositis figure. For HMGCR-associated myositis, in juveniles, this is not associated with statin use. And in fact, there's actually distinct immunogenetic risk factors between adults and juveniles. So targeting the same autoantigen, but likely a different pathogenesis. In cancer, though a serious concern in adult myositis is really in the realm of case reports in juvenile myositis and maybe a paraneoplastic phenomenon. Usually the tip-off seems to be atypical features such as unusual rashes, more prominent lymphadenopathy, hepatosplenomegaly, or even cytopenias. And then calcinosis, which really is confined here to the dermatomyositis group, can be seen across the autoantibodies here. So myositis autoantibodies are used in the classification criteria, the most recent one, 2017 from EULAR ACR. Their anti-Jo1 positivity actually had the highest point score for any of the individual variables in the classification criteria. It was only Jo1 that was included in part because of the sample size available of the patients who were tested and the timing of the criteria development, which was earlier on, had gone over some period of time, and it was not yet when autoantibody testing was routine, and some of the specific autoantibodies that were tested for were more widely available. Now, the lab that I was part of during fellowship, the muscle disease unit, published a paper in 2021 looking at the classification criteria, and they found in a cohort of over 500 patients that it accurately classified over 90% of patients who were positive for an MSA. Now, they looked at a large cohort and they did an external validation in 2 cohorts from the US and from Spain, and found that the presence of any MSA with one of 5 key findings was 100% predictive. So nothing particularly surprising here. We see Gattron sign or heliotrope, arthritis, ILD, CK, and weakness. But the takeaway is MSAs are highly specific, and if we see a characteristic feature, we should have very high certainty about the diagnosis. We also know that myositis autoantibodies can predict or be a sign of treatment response. So this is from a follow-up study of the rituximab in myositis trial, and they found that titers of Jo1, TIF1, and MI2 decreased with treatment. And they also correlated with all or some of the core set measures. So here we can see MMT going up, improving, and the rest of the core set measures, as well as the autoantibody titer, dropping over time. And some smaller studies, not from clinical trials, have observed similar phenomenon, that the titers of MSAs may drop with response to treatment, such as MDA5. In practice, we know that providers are using the results of myositis autoantibody testing. And a 2020 IMAX survey found that in spite of ongoing concerns from the majority of users regarding the reliability of the results, MSA testing using commercial immunoassays is being used globally to inform clinical decision-making. So with diagnostic confidence, the treatment recommendations that came, and the information that was provided to patients. We also found in a CARA survey published last year that that was looking at how providers escalate treatment. There were some respondents that expressed that autoantibody status was an indication not just for early escalation of treatment, but also to guide the particular biologic. And we would frequently see rituximab come up if patients were MSA positive. So I'm excited to share a very recent discovery by Andy Mamming's muscle disease unit at NIAMS, and I was privileged to be sitting at the table as they were working this out over the last few years. This is up on medRxiv for now. So they looked at muscle biopsies with confocal immunofluorescent microscopy and tried to localize autoantibodies and proteins of interest and did some RNA-seq, and then followed up those studies by introducing autoantibodies from patients into myoblasts to try and recapitulate their findings. And they found that in patients with myositis autoantibodies, they accumulated inside myofibers in the same compartment as the autoantigen. I'll show you pictures of that in a moment. Each autoantibody led to dysfunction in the particular autoantigen target. So for MI2, they found derepression of genes repressed by the NERD complex, and in PMSCL myositis, they found accumulation of these strange RNAs that otherwise would have been degraded by the exosome. And ultimately, they posit that this autoantibody-mediated dysfunction leads to muscle damage, and the ultimate immune response. So here's some striking photos, one for MI2, where we can see IgG deposition exactly in the nuclei, which is where the autoantigen is located. In MDA5, which is a cytoplasmic protein, we see immunoglobulin deposition exclusively in the cytoplasm. And I think most strikingly in PMSCL, we only see immunoglobulin deposition here in the exosome in this little magnifying box. So we and others have identified, characterized more novel autoantibodies in juvenile onset myositis, and that inspired us to go back to myositis-associated autoantibodies, which are widely available, clinically relevant, but incompletely characterized. And furthermore, we were interested in determining whether the number of MAAs within a particular patient was somehow associated with disease severity. In a large cohort with just about 550 patients enrolled in cross-sectional studies, NIH myositis natural history protocols, we looked at patients who met Bohen and Peter classification for probable or definite juvenile onset myositis and collected pretty much as much data as we could on their disease and treatment course. We tested myositis autoantibodies with a variety of assays. This was done through the OMRF as well as in-house by the Mammon Lab. And this was the full list of the MAAs that we screened patients for. So we did some univariable analyses and then multivariable logistic regression for the statistically significant findings to adjust for the year of diagnosis and the presence of other myositis autoantibodies. And we used a similar method to determine if the number of myositis-associated autoantibodies was predictive of severe disease outcomes or features. We found that MAAs were present across the different serologic subgroups, and the overall prevalence in this cohort was 36%. Among patients who were positive for an MAA, anti-synthetase autoantibodies were more frequent, and anti-NXP2 antibodies were less frequent. And we found that the greatest variety of these MAAs occurred in patients who were negative for MSAs. So in this upset plot, the horizontal bars here indicate the count of individual autoantibodies. The vertical bars indicate the count for different combinations of autoantibodies. And so positivity is indicated by the solid circles, and then combinations of autoantibodies are connected by lines. So we found that the most prevalent autoantibodies were NT5C1A, row 52 and row 60. And these and others frequently occurred in various combinations of up to 6 autoantibodies. So we first looked at MAAs as a group overall, and unsurprisingly, we found that they were associated with overlap myositis. For these patients, they were older at diagnosis, but there were no other differences between their demographics. And these patients also less frequently had JDM, and more frequently were diagnosed with juvenile connective tissue myositis, which we defined as JDM or JPM with an overlapping autoimmune disease. And the most common overlap diagnoses were lupus, systemic sclerosis, and Sjogren's. These patients, or patients who were positive for an MAA, had features common to other autoimmune connective tissue diseases like arthritis, Raynaud's, and interstitial lung disease, as well as other features such as paniculitis, dysphagia, and regurgitation. So most importantly, we found that MAA positivity was associated with an increased treatment burden. So these patients had higher odds of receiving not just IV methylprednisolone and IVIG, but also second and third order treatments like conventional DMARDs beyond first-line methotrexate, biologics, cyclophosphamide. And they also were treated with greater numbers of medications in combination and greater numbers of medications over the entire disease course. Unsurprisingly, MAA positivity was also associated with higher odds of worse outcomes, specifically a lower likelihood of achieving a monocyclic disease course and a higher likelihood of having a chronic disease course, lower likelihood of remission, and most strikingly, a higher odds of mortality. So as I mentioned a few slides back, this was a cross-sectional cohort. So we saw patients who were all diagnosed with juvenile myositis, but they presented to the NIH at various time points, either during childhood or as adults. And because of that, we did a sensitivity analysis limited to the subgroup of patients who enrolled in these studies as juveniles and found that this association with mortality remained and was actually a bit stronger in that subgroup. We also looked at 3 particular MAAs that are clinically available and relevant, which would be Rho60, U1RNP, and PMSCL. For patients with Rho60, they were present in 9.3% of this cohort. There were no differences in the demographics between patients with and without Rho60. And they more commonly had overlapping Sjogren's, though overall the incidence was quite low. And they were frequently positive for other MAAs, including Rho52 and NT5C1A. These patients also had higher odds of paniculitis and weight loss. And similar to the MAA group overall, they had signs of increased treatment burden, including higher odds of receiving other DMARDs beyond methotrexate, IVIG, and greater numbers of medications in combination and in total over the disease course. They also had signs of worse outcomes, including higher odds of a chronic course and higher odds of being hospitalized. U1RNP was found in approximately 5% of the cohort. And these patients were quite a bit older and more frequently Black. And in terms of clinical subgroups, they more commonly were diagnosed with juvenile connective tissue myositis by quite a large margin. In particular, these patients more frequently had lupus. And similar to Rho60, they were frequently positive for other MAAs, including Rho60, Rho52, and Smith. We found that U1RNP was associated with things like Raynaud's phenomenon, regurgitation, and then cardiac manifestations, including chest pain and abnormal cardiac imaging. Interestingly, these patients had a lower odds of Gattron papules. And like the MAA group overall, they had higher odds of mortality. And this held up both in the full cohort as well as in the subgroup that enrolled as juveniles. Lastly, we looked at PMSCL, which had a prevalence of 3.4%. These patients also were older at diagnosis. And similar to U1RNP, they also had a higher rate of being diagnosed with juvenile connective tissue myositis, here in particular overlapping with systemic sclerosis. And interestingly, which is pretty uncharacteristic overall for MAAs, patients who had PMSCL less frequently were positive for an MSA. We found that these patients had clinical features that resembled the antisynthetase syndrome. Specifically, they had a higher odds of mechanics hands and Raynaud's, as well as interstitial lung disease, and then sclerodactyly, which can actually be seen in both as well. They also had a lower odds of treatment with IV methylprednisolone, but no other differences in other treatments or outcomes. And lastly, we looked at the number of MAAs and whether they were predictive of severe clinical features such as ILD, ulceration, dysphagia, calcinosis, or worse outcomes overall. And so the odds ratios and 95% confidence intervals are presented for the number of MAAs. And here, the only variable that was significant was mortality. So in other words, the higher the number of MAAs a patient has, the higher their odds of mortality. And just like in the other analyses, we looked at the subgroup of patients who were enrolled in juveniles, and this association held up. Note that we also looked at this independent of, or this association was independent of U1-RNP, which we found in and of itself was associated with mortality. So to conclude, in this very large cohort of North American patients with juvenile onset myositis, we found MAAs were present in about 35%, and they were associated with features of other autoimmune connective tissue diseases, more refractory disease, and critically, mortality. Future prospective studies are needed to help us determine whether early detection of these autoantibodies, with resulting more intensive screening for certain disease manifestations and potentially more aggressive treatment upfront, may improve patient outcomes. And I'd like to thank again CureJM for this opportunity to present and for past support of the myositis study group. My really tremendous mentors, Lisa Ryder and Andy Mammon, and all of the collaborators on this work over the years, the intramural research programs from NIAMS and NIEHS, and then the patients enrolled in, and many of the contributors to the study group who I've seen here, who have really made this work possible. It's been a true collaborative effort.
Thank you so much, Matthew, for digging into that important topic. The